Somebody had asked me how I ended up on this path, and I wasn't planning on talking about that, but I was hoping we'd have some undergrads and other people who are considering careers in international health. And I just want to prepare you for the uphill battle that you'll have. Because I know when I got it, and you'll hear this from almost everybody who works with us in Kenya, that every time they tried to promote that their career interest was international health, they're like, what does that mean? What are you actually going to do? It's just nobody really got it. And so for me, when I did residency in this area, and had gone to Kenya for about a month with a program called Share Kenya. And at that time I was very green, had no idea what it actually meant to do anything in a resource-constrained setting. And so when I went there, basically went there, and their goal was to set up primary care. But every year this group goes there for a month a year, and I've been doing this for the past 10 years. And at the end, everybody was like, yeah, we helped this many patients, we did all this. And for me, it was the exact opposite. I mean, to go to a place anywhere in the world and say, we're going to come a month a year and set up primary health care. That in and of itself is ridiculous. And yet at the end of this, we were all patting ourselves on our back and saying, we did this great thing. And so for me, the flight home was incredibly guilt-filled. And I didn't really know how to process the emotions. I just remember being incredibly angry that I was a part of this and that we didn't really do anything except bloat our own egos and think that we saved all these patients. When in fact, we probably detracted more from the local healthcare infrastructure. And so with that experience, that was probably the reason, that strong feeling of guilt and intense emotion was probably the reason why I wanted to make a career out of this and do this the right way in the future. And so I went through public health school, did infectious disease with a focus on HIV and all this stuff, just to have the training that I would need to get a job that eventually would allow me to do it the right way. And I thought, yeah, now I'm set. I've finished all my school. And then I went to job interviews. And basically, I thought I went to a nice public health school, did a good residency, and basically got laughed out of interviews. Didn't get a single call back. I got 3 phone interviews, and they're like, yeah, we'll call you in a week. They never talked to me again, because I'm like, I want to go and set up an international practice site and do things the right way. And they're like, yeah, that sounds nice, but we'll take the next person. And so for anybody interested in a career in global health, it's going to have to be you who's the driving force behind doing it. And every now and then you'll get lucky and find somebody who sees your vision and will give you the opportunity to do it. And the reason why I'm kind of thrilled to be here at Duke is I think Duke has really created a lot of opportunities for people I work with in Kenya, especially the Kenyan physicians that when I first got to Kenya in my first year, I remember working with Dr. Akonala, who some of you might know as one of the Duke cardiology fellows. And he was the first guy I rounded with. And so when we started our anti-coag program, that was the doctor we worked with. And so you're really creating a whole world of opportunities that they would have never dreamed of at that time. And so thanks for doing that. And I think it's great to see it finally come. It's great that I can talk here. And before we do any presentations, we have to give our disclosures and conflicts of interest. So I'm somewhere in this mess. I don't know how many Tar Heels we have in here, but this is from the 2005 National Championship. So I never imagined I'd be doing a presentation at Duke, but here's my disclosure. And then just another one, I'm a Temple grad. And so I made the mistake, or I had the good fortune of going to Cameron Indoor to watch Temple play. And we tricked some band guys into taking this picture. So we brought out our Temple flag just as they were about to take the picture. And so this is our Temple version of Shashevskyville.
But did you win?
I was not going to bring that up. We came close. We put up a good fight. So you had to bring that up. Right? So as a kid, my whole family went to Temple. And I watched Mark Macon, the whole, the 80s dynasty of Temple. And every year we get beat down by Duke in the tournament. So I'm always a little bit bitter towards Duke. That's why I wanted to disclose that if you hear some bitterness towards Duke, it's because of your basketball program. Yeah. So for the presentation, I wasn't quite sure of the audience, so I wanted to make sure I was broad enough to touch on something that everybody was interested in. But I wanted to give some background on AMPATH for those of you who don't know about the AMPATH program, discuss different dimensions of global health, analyze some of the newer strategies that I think I really want to emphasize upon people that we need to take to start making development a different entity than it's been in the past. And then lastly, talk about diabetes care. And then, I don't know how many of you know Tim Mercer, but he's one of the residents, medical residents at Duke Hospital. And so I wanted to talk about the Street Kids program that we run, because there's a lot of opportunities for people to get involved if they want. And just to give you some notion of the design of our program and how it started, so Moy Teaching and Referral Hospital and Moy University School of Medicine partnered with Indiana University School of Medicine to create this IU-Kenya partnership. And everything was going nicely. The original goal was to create a med school, the second med school in Kenya at the time, so that you could start training more doctors. And this was in the early 80s, maybe even 1979 it started. And what had happened over that time period was we had Indiana University physicians who kept going back to the program. And then one physician, Joe Manlin, went there for a longer and a more extended period of time, and I think it was his second or third visit. And so what he noticed was that the whole landscape of medical care and everything that he had seen in Kenya when he came there years ago to build a med school had completely changed with the HIV epidemic. And so basically the focus had changed, because what's the point in training med students if you're training them to basically watch patients that have a treatable illness die? You're basically defeating the whole purpose of the med school in the first place. And so the focus changed from this partnership for med school into AMPATH, which is now in the process. At that time it was the academic model for prevention and treatment of HIV/AIDS, and that was very necessary to address the large pandemic of HIV at the time. But as time has gone on, we realized that there's a whole world of other diseases out there that you need to address. And so being a provider or any level of person in this setting, to set up a beautiful HIV program and have all the other disease states that you see there and do nothing for them was never acceptable to us. So even as we were doing the HIV program, we knew that in the back of our mind, the HIV program was the cover for doing everything else that the healthcare system needed. And a lot of people critique this whole stovepiping and siloized care, but at the time you have to realize that it was necessary. And that's the cover for getting in and doing everything else. And now our program is the academic model providing access to healthcare. And I'll talk a little bit more about what that means. And so this is a map of all of our sites. Our main site is in Eldoret right here. And then all the dots represent our clinics. So we have 55 sites throughout Western Kenya, serve a catchment population of approximately 2.5 million, and have an HIV prevalence between 2 to 30%. This slide is about 2 months old. It's now greater than 140,000 patients ever enrolled and over 82,000 active patients with, I think it's around 45 or 47,000 on antiretroviral therapy. And for the people who've worked internationally, you can imagine the logistical challenges of doing this. So you're delivering HIV drugs to all of these sites, and trust me, the roads are not very nice. It's very difficult to travel, and you have this many patients who are actively receiving care. The logistic challenges are a nightmare. But at the same time, we've never had a stock out of HIV drugs in our setup, which is something we're all very proud of. And so now, of course, I want to transition more into the next step beyond HIV. And I don't just work with diabetes or chronic disease. I work with the overall leadership team. So if you have questions about any specific aspect, let me know. I just wanted to focus things a little bit. And I wanted to explain why focusing just on HIV was good in the beginning, but the need to focus on everything else is even a bigger challenge and an even more important challenge. Because when you look at figures like this, you realize that chronic diseases outside of in AMPATH now we consider HIV a chronic disease. So for this chart from the WHO, it basically goes to show you that chronic disease deaths mostly come from lower and middle income countries. And so to not address it would be to miss a huge portion of what the population actually needs. And so you can see here 80% of those deaths occur there. And I mention this, it might seem obvious to most people, but I mention this because whenever people come and see the work I do in diabetes, the first thing they always say is, "There's diabetes in Kenya?" And I'm very quick to tell you there is diabetes, and it's a different brand of diabetes than you've probably ever seen. And I'll give you a little data that explains that. And if you have questions, please feel free to ask. And so, once again, AMPATH, just to give you a little more background, we have a whole comprehensive model of care, and I could do an hour presentation on any one of these, but I won't bore you and make you suffer through that. So if you have questions, feel free to ask, because I work with all of those departments. But over here to the left, this is what I really want you to focus on, is our program no longer is just HIV. We have robust and vastly and rapidly growing programs in all of these areas. And I'll focus on diabetes since I work there the most, but we have programs in all of these. And just to highlight and give credit where credit is due, I think Duke has a large presence with the cardiology program, pulmonology, and maternal and child health. And so definitely large areas for growth there as well. Jerry, I know I'm from Kenya, but we start on American time.
I figured we would just be starting.
So if you ever come to Kenya, almost every meeting will start at least a half an hour late. I'm sure Cynthia, Ralph, and the rest who've been there. I don't know if you've changed it within your team.
Absolutely.
Well, good. Congratulations.
She's got a new bullwhip.
There you go. There you go. Good.
Hey, John Lawrence has done that.
Yeah. Oh, yeah. Yeah. I can definitely see that.
He's calling on the phone 5 minutes late. Where are you?
I come to meetings. I come to John Lawrence meetings early now.
Yeah.
And it's with my pharmacy team. I was such a stickler for that they now actually make me buy lunch if I come late because I always come late anymore. But yeah, so we have programs in all of these areas.
Should you buy lunch?
Here it is.
Very nice. And so one of the other big things to understand about AMPATH, and I give a pretty frank and honest description of what we've been doing. So with HIV, a lot of criticism towards AMPATH was that we did it in parallel. We are not an NGO, but we partner with the government. For HIV, we kind of partnered with the government, but didn't have to go through all the bureaucracy of government. So we had our own parallel administrative structures, our own providers that responded to us. And so that was one of the big critiques of AMPATH. But now that you're trying to do primary healthcare, that whole list of diseases, there is no way we have enough funding or enough manpower to do it on our own. So what we did was we went and joined an agreement with the Ministry of Health to do primary healthcare and chronic disease so that we can actually formally partner and develop something like the world has never seen to address chronic diseases and primary healthcare. And so just to give you some of the details of this, since I'm going to focus on diabetes, I thought I would leave this up there. But you can also see here that we even have a special listing for cardiovascular and pulmonary care. And the reason I mention this might seem easy to people once you see a document like this, but to get all the different players that we needed to get to sign this document and create this document took 1.5 years. And so it might seem like, oh yeah, that's nice, they've got a partnership. That's the hard part. Doing it is easier than actually getting all the right people on the same page to actually agree to do it. And so we have kind of a blanket approval to innovate with the government.
Isn't the dean there a public health person?
The dean of the med school?
Yeah.
Dean IU, I don't think he had a public.
Or the former.
Yeah, the former dean was. And so Dean Essemai was the former dean. Now he's the vice chancellor of the Department of Health Sciences. So Essemai is now leading that. So all the relationships we had with him will now benefit our program even further. But Dean IU is an interesting character. If you ever come back, you should definitely talk to him. One of the other things that happened with Dean IU is he worked for AMPATH for years. And so we have great support from the School of Medicine there as well because he works with the school. And his firstborn is named Manlin, in case anybody wants to know. Joe Manlin being our program founder. I can give you the whole story on that, but we'll leave that. Yeah. And so, over 5 years, I've tried to learn about how things work and why they work. And what I realize is I've become more and more jaded and cynical for people who've known me for a while. This is actually a picture of our diabetes care program and some of our patients. What I realize is that a lot of this development type stuff, if you really break it apart, it's designed to fail. The fact that it works is more of a miracle than anything else. And so if you look at this is our care program, and these are all the patients that we support. So if you look at funders, the competing interests of funders, basically the things that we see is funders have focused interests, they have their own deliverables, they work on their own timelines, and for us, getting that document signed took us 1.5 years. And the funders are like, oh, that should take you 2 weeks or something. And we can't start anything until we get that. And so the funders are yelling at us like, you haven't met your deadlines, and so they have their own interests. But for us to do it in a sustainable way, we have to make sure we have that document in place. Then there's also funders who want a vertical program. They want you to just focus on this one thing. But that's when you're a clinician on the ground, that's not the way you operate. It's not like you say, okay, well, you have diabetes and you have hypertension. All right, I'm going to take care of you, and then you just go away. That's how things would run if they ran the way that funders or people wanted them to. But the clinicians on the ground don't operate that way. And then also, if you're dependent on funders for your funding, when the economy starts to tank like it did, like it has been doing over the past couple of years, then also your programs that are dependent on it, they start to take a hit too. And so universities, and so even with myself, I'm faculty at Purdue, getting them to understand what I do on a daily basis is a challenge. And I'm sure anybody who's worked for a university and works internationally faces the same challenge. This is a tenure year for me, and so you can imagine the pressures I'm under, but at the same time, the pressures that speak to me are the ones that I see on the ground every day, because I spend 11 months a year in Kenya and 1 month in America. And so all the things that bother me are the things that I see there. And so, my university wants me to write more grants. They want the money, they want the indirects, and that's the way the system's designed. At the same time, there's more and more students who want to come. And that, of course, takes my time away from doing the administrative stuff, doing the stuff to lead the program, and then also budget reductions. If you're a university administrator and you're having budget reductions, what do you think you're going to cut first? The programs that are right in front of you, or the programs that are halfway across the world that you spend maybe a week at, every 5 or 6 years? And so, that's another thing that helps or hurts, some of these activities. And so then research, another kind of thing that's muddling the picture is the research can also sometimes detract from what you're trying to do for care. Like for me, these patients here are the main reason I do what I do, is because I want to serve them. But once you start getting research grants, your priorities start to be dictated by the research. And so that's another thing that gets in the way. And then collaborators. So collaborators like me. My promotion criteria are based on what a Purdue faculty member in America would do. And I don't do anything that a Purdue faculty member in America does. I mean, we're setting up care programs at a scale that's probably larger than anybody at Purdue does. I mean, when we talk about numbers, we're talking about millions and hundreds of thousands. A pilot to Joe Manlin is, 50,000, 60,000 patients, and that's a whole care program in most parts of the world. And so understanding those kinds of challenges is also difficult. And then cultural differences. I think, we could have a whole discussion on the culture of management there and the culture in America, and those are also challenges for anybody who's trying to immerse themselves in this. And then also limited resources, which I've already touched upon. And then you have local government. Local government wants more funding too. Why not? If Develop USAID and other funders are going to get more money into this, I want some of that too. And the lesson that they've learned is if they keep asking, they'll get. And even when they mess up or use it inappropriately, more money still comes. And so, there's a governmental piece to this. And then also, there's very limited incentives for developing a functional system. If, let's say, all of a sudden Kenya decides to solve their problems and address all the healthcare needs, the funding that they get from outside sources is going to go down. And so even the incentives of the system are designed to say, well, diabetes is a huge burden and we're not doing anything about it. It's better for them to say that if they want funding to actually address it. And then, lastly, here's the local providers. A lot of times when I have students come in, they say a lot of negative things about the local providers. But one thing I'd encourage anybody here to do is understand what they're up against, or understand what their system is putting them up against. I mean, they're in a dysfunctional system. And most of us, if we were working for a hospital and felt like we weren't able to help patients or weren't supported, we would, for the most part, leave. These guys don't have that option. And so they're kind of pulled away from doing the things that we think they should be doing towards other things where they think they can be productive. And so there's research incentives. The more research to do, the more money they get. There's a lack of accountability. There's lack of a functional system. And private practice is there. Right now, we're having a nationwide doctor's strike because they haven't received a pay raise in quite some time. And so all of the things are pushing them outside of that public sector. And all of those patients that you see in there are essentially covered, and you're basically prevented from actually getting to the patients because of all these competing interests. And what I encourage anybody to do as they start working internationally is don't look at just the surface. Look at all the things underneath it that make the system the way it is before you cast aspersions. And I've learned this the hard way, where I know my first couple months there, I just couldn't understand why the nurses weren't as caring or whatever you want to call it in America. And it's actually because the system has beaten them down enough to a point where the more they care, the more they try, the more they get yelled at. And so it's a lot of the system factors that actually do that. And so I wanted to take an example of one system that's failing and our approach to it, just as kind of like a very brief case. And so I work with the pharmacy side of things as well. And so drug access, when you're trying to do chronic disease, primary health care, and all the rest, is a huge issue. You're not going to go anywhere unless you have access to those drugs. And even with the cardiovascular program, it's a huge challenge there. And so on this side, these are some of the players that potentially have the solution and have the drugs. And so KEMSA is the Kenya Essential Medicine Supply Agency. And so they're responsible for supplying all of these governmental facilities. But the supply chain has never really been worked out. They have incredibly arcane systems for delivering drugs. One example is they have the push system, where basically you go to one of the clinics and you give them a package of drugs. They give you whatever they give you based on no data and just based on what they think. And so what we see a lot of is certain clinics have tons of malaria drugs but don't really treat malaria. And so their drugs are just expiring because the government is just pushing drugs to them in a very haphazard way. So you're not really getting drugs to the patients that they actually need because you're not providing the right drugs. And so that's one thing. And KEMSA has its own set of challenges and have been underfunded, and there's been talk of corruption and mischanneling of funds and money, and so that's not really working. Then you go to USAID. USAID prevents you from using any of the money you have from them on non-FDA approved medications. So you can't use any of the funding you have for AMPATH to buy those drugs. So that's another thing that's going on. And then you have patients who, for the most part, have some ability to pay. But in the government system, it's incredibly difficult to create a payment system that's very transparent and accountable. And so that's one side of the equation, is those sides. And then you look over here. So you have staff in these public facilities. AMPATH only works in the public sector. So you have staff at the in these facilities. They all run their own private clinics as well, whether they'll tell you that or not. They all run their private clinics. So as the government facilities get better, what do you think happens to the income they generate in their private clinics? It goes down. So once again, the system is essentially incentivizing them to make the government system fail. And so these are the things that you realize. And even if you have drug costs in your private clinic and there's no accountability over how you manage the drugs you're getting from the government, what do you think people are going to do? The same thing they do here. They start stealing drugs and selling them from their own clinic. And so this is the kind of stuff we see. And it's not, one of the things I've learned not to do is, these problems are not Kenyan problems. These are people problems. People everywhere would react the same way. Just in Kenya, it has a much bigger impact because there is no backstop. If patients go to the public sector and they don't get care, they basically go back home. In America, if Duke for some reason shut down, they could go somewhere else and it wouldn't be the end of the world. Whereas there's really no other alternative. And so here's just kind of a snapshot of what the drug supply availability was. And so this is, we looked at all the essential medicines that they're supposed to have and found in our cross-sectional assessment that they only had 40% of the drugs available in Vistoria, if you look down here, and in Turbo, which is another clinic, they only had 36%. So that's just another thing. And so obviously, you can think of a very simple system, and this is what the current system is in the ministry side. So basically they have a pharmacy that's already there in the government side. And patients pay a small amount for the drugs that KEMSA provides to them. And so that ministry pharmacy gets some of that money back. But the money never goes back into the pharmacy. It goes back towards casual laborers, the lab, salaries, infrastructure, everything else except for buying drugs. And so what we're suggesting with the revolving fund is change this model around. You're actually making money on those drugs. Why not just put the money back into the pharmacy and buy the drugs? Like, it's a genius idea. But it seems so simple and so stupid, but you can't imagine how much resistance I got to this idea. Because I've been saying this from the day I got there, and I can tell you, almost every time I mentioned it, I got laughed out of the meeting or was told, these patients can't afford it. There's no way they can afford any of this stuff. And I'm like, they can afford it. I trust me, they can. And just got laughed out of meetings. And so we've actually just said, forget it, let's do it. And so for the more critical, analytical people here, you start thinking, well, if you set up your own separate pharmacy and start selling drugs, what's going to happen to the ministry pharmacy, right? The government pharmacy is going to fall apart because you're basically setting up a separate channel where you have reliable supplies and everything else. So things we did to avoid that was we charge more than the Ministry of Pharmacy. So the government still should feel a pressure that they need to keep their governmental side of pharmacy stocked, because if patients are going to want the drugs at the cheapest price. So our goal is not to put the government pharmacy out of business, our goal is just to provide access to medications. And so that's how it's actually worked. And if you have questions about that, please ask. I'm giving you a very brief overview of what we've done. And one of the great things is we're talking to the cardiology folks about doing something similar. And it's worked with great success. And here's just some data to show you what the success is. Key assumptions that you have to keep in mind with revolving funds is we assess those same drugs that we assessed before for Mesuriad and Turbo. We set the price 10% higher than the government price, not for the sake of making profit, but for the sake of not eliminating the government pharmacy. Because our goal is that our pharmacy is eliminated. If drug supply gets to a point in the government side that we don't need to be there, hallelujah, less work for me. That's good. And so other things just to keep in mind here. And so this is the data that I was talking about before with availability prior to our revolving fund concept. And here's availability 5 months after the revolving fund pharmacy. 94% of the drugs that are on that list of 75 essential drugs were all there. And our profit margin is 48% and 42% from the other side. And just to give you another interesting story, I work a lot with Joe Malin, and he has tons of stories, so I like stories. What we found in the first couple months in Mesuriad, which is one of our first clinics, was that when we did this revolving fund pharmacy, we actually made more money in this one revolving fund pharmacy than in the entire Mesuriad Health Center. So this includes everything from the labs to the registration fee to everything. And the Mesuriad people were like, wait, what are you guys doing? This is not right. Something is wrong here. And so what they realized was one of their committee members was basically stealing about 60% of the money from the hospital every month. And so when they looked at their money, they're like, it's not there. And so the fact that we actually created a transparent, accountable system is what led to them figuring out that their system was being pretty much milked for 60% of their funds. And so the revolving...
All those are set up that way. The more you can move the money around, the more somebody can... And then it's usually somebody's brother, cousin, uncle, whatever.
Yep. And so we showed them the data, and because they were ready to shut us down. They're like, no, you guys are making too much money. This is not right. You guys are doing something corrupt. But we have very clean books. We have documentation of every drug. Everything is there. And we're like, no. And our thing is, we're not even taking the money. We're reinvesting the money back into that pharmacy. So it's not like we're operating in a for-profit mentality, but it just gave them enough insight to realize something isn't right here. And so now that that health center is getting that money back, and everything is good. We're actually taking this model to the lab and are expecting to have great success. Now, one of the challenges with this is when you're talking to donors, as I mentioned here, 10% of the drugs were from donations. We have a donation program with Lilly and other partners like Abbott. And so one of the challenges was they said, you can't sell our drugs. We gave them to you as a donation. That goes against the tax code and all this other stuff. But if we give those drugs away for free, then even the government supply chain is kind of just, it's obviated. They don't need it anymore. And so I pushed them and said, no, I'm selling it at the government price at a minimum. Because if I give it away for free, I'm going to create that same vacuum that we created when we went to Kenya however many years ago for a month and gave away care for free. It's going to create that same vacuum. And so when our supplies are out, patients aren't going to buy anything. They're going to want it for free. And so this is actually taking us on that separate path where we're trying to do, instead of doing development, is I call it the bleeding heart Mzungu. Mzungu in Kenya is basically like the foreigner. The bleeding heart Mzungu who sees people and just sees poverty. I don't see that anymore. These are very resilient people who realize the game and show you what they think you want to see. If they know that every time a Mzungu comes, they give them money if they look poor, then they're going to look poor to you. If they realize that you're not going to give them money, they're not going to look poor to you. They're going to be like, okay, help me do this then, and how do I get care? And so what I really want is for people to change their frame of thought when they start doing this kind of work, and get rid of that bleeding heart Mzungu phenomenon.
So how did you get the drug companies to believe that?
What it really took was explaining it to them in a way that they understood. The challenge is, if it was a Kenyan, I don't know if I don't know, I'm maybe casting my own opinions, but if it was a Kenyan that they didn't have a strong working relationship with, I don't know that they would have bought into it. But since they've worked with us for some time, they kind of know what we're about. At least they know what I'm about. And so there was that level of trust where they're like, yeah, these guys aren't trying to pull one over on us, they're actually trying to do something.
But they pulled the tax code line on you to begin with, so obviously there's some way they can get around that.
Right. So basically, they had to talk to the lawyers before they really went forward to this. And what we essentially said was that the money we charge, like it's $2 for a bottle of insulin that we charge now. That's a user fee. It's not for the drug product. It's just a user fee. And so within their language, that's what they did, and that's how they made it okay. But for us, it's what's creating a system that's sustainable. Because even when that Lilly donation goes away, the government charges $2 anyway. And so it can still work, even without us. But if we gave it away for free, as soon as that Lilly donation goes away, those patients are not going to be very happy to pay $2. And even the government facilities where we work at, as soon as that money as soon as patients have to pay there, they're not going to come there anymore. And so we made sure that we started off the right way from the start. So now I wanted to transition a little bit more into diabetes, and I can give you a lot more detail on any of this data or any aspect of this you want, but I just tried to focus on some of the main things. There's some overarching themes that I like to express in my presentation. One of them being that you can't always apply the same exact strategies that you apply here in another setting. And the disease burdens and the disease states that you see elsewhere have a very different pathophys than what you'll see in America. And I just want to give you some data to highlight that. This is a very busy chart, but for those of you who've worked in Kenya, this is what our model is for chronic disease management. And this shows you how we're basically using every level of the Kenyan healthcare system to address chronic diseases, from the highest level of the referral hospital to the community level down here. We're tasking everybody to help us address chronic diseases. And this is how we're going to do it. If you have more questions on that, I can answer it, but I don't want to spend too much time. I'll just give you some of the highlights. Right now at AMPATH, we're doing, it's called Perpetual Home-Based Counseling and Testing, where we're testing every man, woman, and child for HIV in our catchment area of over 2.5 million people. And now we're adding on diabetes and hypertension screening to that as well. And we're doing this via portable phones, like Android phones. And so we have a database collection software in here with GPS that allows us to do that. And we're doing that through this perpetual HCT model. All right, so here's some demographic data from our clinic population. You can see it's a very wide range of patient ages that we have. Almost no patients have outpatient and health insurance. And keep in mind, I only work in the public sector. This is not referring to the private sector. And so very few patients have any form of outpatient health insurance. Very few patients smoke or drink alcohol. But the thing I want to highlight is almost 70% have a caretaker. Now, I only worked in America for a little bit during my training, but I would have killed to have this kind of percentage of caretaker assistance. This is something that would be unheard of in America. Whereas in Kenya, it's almost the accepted norm and the assumption that you have a caretaker who helps you. And it's something that when you're developing a new system for this setting, you really have to take advantage of that. And that's something that we've really done with great success so far.
Sonak, how accurate is that history of smoking?
The history of smoking is accurate. The alcohol use one is probably not quite so accurate. And it depends what you include in smoking. I think one of the big things that we see is a lot of indoor air pollution from the stoves. And that's probably equivalent to a couple pack years each day that they're exposed to that. And so that's a whole other thing which we didn't touch on.
We were debating this. I just wondered what you thought.
We're seeing with Lagat's protocol that we're running into more smoking than we expected.
Yeah, I mean, I don't know. I mean,
Underreported.
Yeah. I can usually smell the smoking on my patients when they come in, and I rarely smell that smell. Now, when I go to a diabetes clinic in America, it refreshes my nose of that smell that I'm used to smelling. And so,
you see them buy one cigarette at a time.
Yeah.
They don't have enough money to have you smoke.
Yeah. So I don't know what the impact is, and we are in North Carolina, so I'll give a little jab at Philip Morris. But what they're really moving to is marketing cigarettes in resource-constrained settings in low to middle-income countries, and so that's definitely a big issue. I don't see a large burden of it in the diabetes clinic, but it could be underreported.
Sure.
Alcohol use, I would guess, is higher, but that one we have data to suggest from other clinic populations that what they report to the clinician is very different from what they would report to a peer worker or a support group, and so that one's probably an underestimate. But the other, I don't know so much about smoking. And so wanted to give you some data that highlights the dynamics of our diabetes population. And so keep in mind here, this is all a diabetes clinic. And this is just, we used a validated scale, but I condensed the information into something that people would understand. And so this is the frequency of exercise per week. And basically if you look at the percentage of patients that exercise more than 3 times per week. It's almost 75% of the population. And the ones who don't exercise are largely not exercising because they can't. They've been debilitated to a point where they can't. So the Society of Diabetes patients that we work with exercise, 75% of them exercise more than 3 times a week. Something doesn't fit here. Yes?
Does that include leisure and work?
Yeah.
As terms of exercise?
So we use the IPAC, which is the International Physical Activity Questionnaire. And so that also includes strenuous activity like farming.
They're all farmers.
Yeah, Western Kenya is largely a farming community, and these guys all farm. And it's always amazing to me when I see these patients. They're 10 times more ripped than I am and have diabetes that is developed later on in life. It's not like they're developing type 1 diabetes, and that's more of a typical picture. These guys are ripped. And they have like forearms, veins are all showing. I'm like, what are you guys doing? What are you taking? Like, nothing, I just farm every day. I'm like, I need to start farming. And so they're developing diabetes. And it just doesn't make sense. It doesn't fit our normal conventions for diabetes. And we've had endocrinologists come, we've had all these people come and just don't understand the pathophys or the burden of diabetes that we're seeing. And then just to give you some more data on this, the BMI of our diabetes population, 25 to 29 would be considered overweight and greater than 30 would be obese. You can see that if everything from here to here is obesity, and it's less than 30%. Diabetes population, once again. And so it doesn't make sense. And there's a good portion that are overweight, but for the most part, they're below below a BMI of 24, which doesn't really make sense. And so the picture of diabetes that we're seeing is very different than what...
Is it very much like, is it comparable to the Asians? I mean, it seems like this looks like China and the exploded.
Yeah. I mean, I would guess it's probably similar. There's actually, there's really good data coming out from India now, where they have urban diabetes, which is very similar to what we see, but they're starting to see and detect this rural diabetes in India. And there's some really interesting articles on that. And we see the same thing here. Like all the things that they talk about, like a person who's developing diabetes in their 30s and 40s, and is very active, and doesn't respond to orals, but responds to insulin, and then has periods of time where they don't need insulin. It just doesn't make any sense. And they see the same exact thing in India that I'm seeing here. And I can tell you the challenge of managing diabetes here is enormous. I feel like you're always on the balance of killing them with insulin or saving their life. And you never quite figure out which side of the balance you're on, just because I'll show you why that is. So food security is another big issue. And so this is just looking at food insecurity. Almost 35% of our population reports some level of food insecurity. Once again, diabetes population does not fit, does not make sense. Why is 1/3 of your population food insecure? And so now, for anybody who's managed patients with diabetes, imagine giving insulin to somebody who's food insecure and trying to figure out a stable regimen to give of insulin. It's an incredible challenge. And I feel like any day we can kill a patient just by increasing their dose by 2 units, which doesn't make sense. And when we have the endocrinologists come, they're like, no, you have to push that dose up more. I'm like, no. Don't, you'll kill patients. And our starting dose for insulin, I don't know if we have any endocrinologists or people who manage diabetes, our starting dose for insulin is 10 units and 6 units. And our average dose over the course of a day, once people get stabilized, is in the 30s. So around 30 to 40 units is the average that we get to, which is a very low dose of insulin by American standards. And so I don't quite
have
understand.
insulin resistance at all.
Yeah, it's just a very odd picture that we see there. And so here's just more data. We're about to publish a paper on food insecurity. And so this shows you, this kind of validates some of our findings with our food insecurity scale, where almost 40% of our patients who are food insecure are on insulin. And then this is the food secure population, statistically significant difference. The mean BMI of the food insecure population is lower compared to the food secure population. Age of diagnosis is lower. I don't understand the female gender part. And the A1Cs are generally higher, not statistically significant. But what it also shows you is that the A1Cs in our population are, for the most part, much higher than anybody would ever tolerate. But now keep in mind, what do you do when you have a food insecure patient and you're trying to get their blood sugar control better? I haven't quite figured it out yet. And so that's one of the big challenges we have. So one of the things we did was we started up home glucose monitoring, where we gave patients glucometers and had them test their blood sugars twice a day. And here's some of the data from that. the reason I like mentioning this is because even when we started this, a lot of people were telling us, no, like these rural patients, they can't check their blood sugar twice a day, they can't write all those numbers down, they won't do all that stuff. Our patients have about 98% compliance with checking their blood sugars twice a day, which I'm sure would blow away most of what anybody sees in diabetes clinics here. And the other reason I mention this is even when we were starting to think about doing HIV care in sub-Saharan Africa, Andrew Natsios, who was heading USAID, said, Africans can't tell time. How do you expect them to take drugs 3 times a day? And it's all nonsense. If you look at the compliance rates for HIV, our compliance rates are probably higher than most clinics here. And even with diabetes, our compliance rates to the things that we're prescribing are much higher than what you would expect in any other setting. And so what we realize here is if you bring it, they will come and they will succeed for the most part. And if you do it the right way, patients will really do well. And so you can see here, this is just some summary data. The mean A1C when we enroll patients is around 13. After 3 months, it drops to 10.2, and then we kind of plateau at around the mid-9s. Because once you get there, then they start getting so much hypoglycemia every time you increase the dose. And so almost all the patients experience an improvement in their A1C.
How many people do you have on performance glucometers?
Now?
Yeah.
So this data looks at 135. If you look at it now, I think we're up to about 210. And so we're about to present a paper on that as well and do other data analysis. Yeah.
In this data collection, though, they're writing the numbers on paper. They're not using the telephones for data collection.
So no. So the patients write all the numbers down in their own little books.
Okay.
We call them once a week and get all the data, and then enter that into our database. And we generate graphs of all the results and have clinicians who look at all the data. We're not doing phone capture. We actually wanted to do that and give the patients phones and have them enter the data themselves. But what we needed was the other information. Like when your sugar went down to 1, I can't, what is that? That's around 20 in American units. I want to know if you felt hypoglycemic, if you didn't eat. That's the stuff that is very hard to capture in a phone. So we actually tried to go to that model. And we actually were toying around with the idea of having a Bluetooth glucometer with a Bluetooth phone and automatically transmitting the data. But it's not that useful to us because we want to know all the other details, all the clinical stuff. And so that's some of the data from that. And this is a rural clinic, just in case there's anybody in the group who agrees with Andrew Natsios. This is the A1C results from our rural clinic, which is 10 times better than what we see in our urban clinic. These are A1Cs on the y-axis, and these are months of enrollment. You can see so many of these patients who had A1Cs that were through the roof just start plummeting. And we were actually victims of our own success, because for some of these patients, we dropped their A1Cs so fast, without intentionally doing so, that they started to get peripheral neuropathy. They started to get complications because they were so used to high blood sugars that their body didn't know how to cope with normalized blood sugars. And so most of these patients are stabilizing out to more normal blood sugars.
And develop peripheral neuropathy as you drop?
Yeah, it's crazy. It was, I'd say about, if they had more than a 3 or 4 point drop, they had de novo peripheral neuropathy.
That is crazy.
Yeah. And so these are the kinds of things we're seeing. And other pearls that you might want to take note of, the peripheral neuropathy you see here has a lot of ischemic components to it.
Right.
What we see there is almost completely neuronal. Like it's all based on high sugars for a long time, just eating away at the
So
nerve.
it's all reversible?
For the most part, we think so. Sometimes it gets to a point where it's not, but it responds pretty quickly. Once you start normalizing the sugars, it goes back to normal. And so that's what we're seeing. And since Tim Mercer is a resident here, I had to give a shout out for the 2 Miami Street Kids Center and also show you how we're using a lot of those market-based strategies that I mentioned before and changing our notion of development to do something for street kids. And for me, with the street kids population, every time I would go into town in Eldred, you'd have street kids coming up to you. And I'm not a person who likes feeling helpless or powerless to do something. And you knew that if you gave them money or you gave them food, you were probably doing them a disservice. You're just incentivizing being on the street. And so what we said over, it took about 2 years of planning, was we want to create a drop-in center. And Tim Mercer, one of your residents, medical residents here, was really the driving factor with that. And he was smart enough to realize that he probably wasn't going to be in Kenya full-time, but we were. And so he convinced a bunch of us, like, I've got this idea for setting up a drop-in center. Can you guys help me and partner and do all this stuff? And I'm like, all right, Tim, fine, why not? And so we really kind of pushed it, and now we have the 2 Miami Center in Eldoret. And I just wanted to show you pictures from one of the projects that we did a little bit long after these slides. But this is just a background on street kids. I don't want to spend too much time on this, but street kids are probably one of the most vulnerable and difficult populations to work with because they've got abandonment issues, they've got substance abuse, and it's a large growing population. Every time a setting starts to urbanize more, the street kid population starts to go up. And this is what you see consistently throughout the data. And they're also very independent. Like these are 7, 8-year-old kids who have been living on their own for the last 7 years of their life. And so they don't need you. They don't want somebody to tell them what to do. And so you have to understand a lot of these factors before you start implementing solutions that really take away a lot of their freedom. And so this is what we see with the elder population. There's around 1,000 that were estimated in 1997. Now we expect it's around 3,000 street kids who are currently roaming the streets. And so we did a project to really kind of educate people and increase awareness about what the street kids are actually going to. Because I know when you see them on the street, you almost dehumanize them. They're not kids to you, they're just nuisances. And I say this because I was the same exact way. And for those of you who come to Kenya, you'll know what I'm talking about. And I'm not saying, I don't say that proudly, I say that's what people do to make themselves okay with it. And so these are pictures from a project we did where we basically gave the street kids Polaroid cameras and said, take pictures of your life and we'll do a photo exhibit. And so I think Tim Mercer also did a presentation of this at another session, but these are just some of the pictures. And to me, they're very striking. I mean, when I looked at this picture, I basically just stood there for 10 minutes and didn't know how to process it. You basically look at this picture and you see garbage, and you almost lose sight of the fact that there's a kid who's laying right on top of the garbage. And he just fits into the landscape now. And being in Kenya long enough, it's just something you accept. And we don't accept that within the Tumaini Center. And so that's one picture. And then this one is also particularly telling. It's amazing to me that these are kids who took these pictures. And so if you notice this thing in the background, this is actually just a big pickup truck that was passing by. And so for whatever reason, the kids decided that it would be a good spot to take a picture. And these are some of the street kids in our program. But it's almost amazing to me. If you look at this picture, it's almost like the street kids are trying to integrate themselves into that life. The dream, family structure, you're in the supermarket shopping, the Western lifestyle. And it's like the kids are somehow superimposing themselves on that life, but it's far enough in the background that they just can't get there. And so this picture to me always gives me the chills and makes me step back and think about, these aren't dehumanized little monsters like they're treated in Kenya. These are little kids. And when you come to the center and take them out of all the challenges of the street, they act like little kids. They want love, they want affection, all these things that they've been denied throughout their life. And so for me, working with the Tumaini Center is just another program that allows us to address a huge need in Kenya, and we're trying to address it the right way. And I'll show you some of the initiatives that we're doing. So, we're not imposing any specific rules on the kids. To get the kids more interested, we set up soccer games with them, and we play soccer with them. We do outreach and do all these things. And the students who come actually go and play. That's an IU medical student who actually used to play soccer in university. And so one of the things for any girl soccer players in here, please join my team when you come, because the Kenyans will never think that you know how to play, but I know that you know how to play at the university level. And so almost I can even tell you with her, she's a tiny little girl. When she joined our team, we have a formal team there that plays every Sunday. She scored 2 goals in the first 5 minutes because none of the Kenyans would ever cover her. And so, and then after that, then they started covering her. So if you have soccer skills, please join my team. I respect. I'm all and so I wanted to also kind of show you how things come full circle. What I realized with the street kids is it's just a bunch of opportunity costs. Their decision to be on the street is the best option to them at the time. And if you give them other options, they'll throw away their glue. They'll go back to school. They'll do that stuff if that's an option for them. And so here's one of the programs that we've done where we basically have the girls make these diabetes bracelets because, as I mentioned before, with diabetes care, they go hypoglycemic a lot because they're food insecure. And in America, most diabetic patients have the identification bracelets or the medication alerts. Those things don't exist. And so basically we combined their need for a job to make a stable income with the needs of our diabetes program. And so now they make diabetes identification bracelets that we give out to patients with diabetes. And I charge the patients to buy them, but the prices that patients in Eldoret are willing to pay is less than what my cost is. And so I'm still trying to find a way to find a better market for them. But it still serves my goals of helping patients with hypoglycemia be detected with having actual hypoglycemia. And it also provides the girls with a stable income so that they're not on the streets. We've also had great success with getting kids back into school, which is no small feat. For anybody who's worked with street kids, you know how hard it is. And if you look at things on the surface and you say, well, look, any kid who comes along, I'll give you money to go back to school. It never works. You have to really dig in deep to why they're even on the street. And there's tons of stories I can give you about that. But most of them, if you give them money, will go right back to the streets after a week, because that's not really how it works for them. So we open every day, or I think it's 4 days a week now that we open, and the kids are able to come there, get services, and then we work on the case management that's necessary to get them back to home and get them back into school. And so these are two of our first success stories who are just about to start university, who are street kids, 2 or 3 years ago. And so it's all working, and we're not developing the way that development has always worked, where you're just giving out stuff for free. I don't really believe in giving out stuff for free. Even in the Street Kids Center, we developed a point system. We get a lot of donations of clothes from visitors who come to our center. And instead of just giving it to the kids for free and devaluing the value of those clothes, we create a point system where the kids earn points if they behave well, if they attend classes, if they do all these things. And then they can use those points to buy the clothes, so that they actually get, they actually are earning the clothes, and it's not that we're just giving it away for free. And so it's actually worked quite well. And so those are some of the initiatives that we're working on. If you want to get more involved, this is our newest project. We're trying to make Christmas ornaments. And so for next year, if anybody wants to be a distributor for us or knows somewhere where they can sell them, that's one of our Rudolph Christmas ornaments that the kids have made. And if you want to check out the website, here's our website. And you can also email me if you have any questions on any of these aspects. But thank you.
Who's working on this in terms of trying to figure out why these Kenyans are getting diabetes at such a low rate?
So there's a couple different theories. What our hope is now that we're going to, I showed you that map that showed you that we're getting to every level, we're about to expand diabetes care in a large fashion. And we're hopeful that we can start to identify some of the risk factors, post hoc, from looking at such a large sample. One of the big areas of research that they're looking at is maternal fetal programming. Is that malnutrition of the mother in utero while they're pregnant is actually something that might predict diabetes in the kid of this unique rural fashion. What people are actually thinking is that prolonged states of malnourishment actually shock the pancreas and create this weird setting where their pancreas stops making insulin. That's what one of the theories is. And so a lot of the data and the support from this actually comes from bulimic patients in America, in the Western setting. And so that's where they saw this brand of weird diabetes. And the larger studies are actually done with those populations. There are some studies that are coming out from India, Nigeria. There's one in Ethiopia, and then Sudan. There's some studies that are coming out, but still has not really been described. Other potential thoughts is that there's environmental causes, and also their diet for people who've been to Kenya. It's largely a corn maize meal diet. Ugali is a staple food, and when you're hungry and you don't have money, ugali is cheap, and you eat lots of it. And so you're not really getting a balanced diet either. And so that's another kind of theory that's thought to contribute to this. Yes.
How do you quantitate food insecurity?
So it's called the FANTI questionnaire. It's Food and Nutrition Technical Assistance Document. So it was developed for HIV patients to start addressing food insecurity. And it's validated by USAID. It's called the FANTI project. And that's we've done that in a large scale for our HIV population and found that the rates of food insecurity within the diabetes population is the same or a little bit higher than what we found in HIV. Our HIV population had around a 32% food insecurity rate. And so it's FANTA. You can just type that in on Google and you'll find all the links to it.
But
so we use that scale.
when you say food insecurity there, can you translate that to like
so
missed or whatever?
Some of the questions that are asked are, did you ever go to bed hungry because you didn't have access to food? Things like that. Questions, where, how many meals did you eat in a day? Was it because you didn't have access to it, or was it because, you didn't have time? It just kind of teases out the dimensions of food insecurity.
Is there a similar thing for alcohol intake?
There's, what is it? I think it's called the CAMP questionnaire. I don't remember. There's a whole validated scale for Kenya for alcohol abuse that we're using. It's basically looking at what patients. It teases out alcohol abuse versus just consumption of alcohol, and so there's a validated scale for that as well. I can send you the questions if you want.
I'll email you.
Just shoot me an email.
We live in a community where sugar cane is fermented. Nobody can afford to buy it, but I wonder if people aren't getting access to the grain alcohol and whatever.
Of course,
the
I mean, North Carolina.
Yeah.
You know,
Yeah.
grain alcohol.
And that's a
Leg on moonshine.
that's a big deal in Kenya, and I'm sure Jerry's seen a ton of dilated cardiomyopathy. I know we've seen a ton of patients in Kenya that have that from brewing. It's called Changa and Musa in Western Kenya, and so that's a big business there as well, is brewing illegal brews. And I think they ferment corn, is it?
Yeah, maize.
Yeah, they just ferment maize and develop their own alcohol, and so that's.
How do you know so much about it?
Patients have told them.
When in Rome.
I'm going to Kenya. I like bourbon much better than rum.
So I mean, in just in the last couple of minutes. So what's next for you? Where does your program go, and where you see this in the next 5 years or so?
Yeah.
Expanding, all the different things that you've done and are doing.
I think it's a great time of transition. I think, and just to tell you, the people who laughed me out of meetings when I mentioned the revolving fund pharmacy concept were a lot of the leadership of AMPATH. And now it's their idea, which is great, because that means that we'll spread it. When they talk to people now, like, yeah, we've got this great revolving fund. They finally like it. And so I think, for me, where I see things moving is moving towards more of this non-bleeding heart Mzungu model, where you're actually developing systems that are sustainable and have some contribution of patients in there. And so that's how I would say the overarching model would be. I think one of the big things is USAID is really starting to get behind AMPATH's approach. And so they're hopefully going to, they've agreed to maybe fund AMPATH's rollout of this to all 55 sites. Right now, this data is just from a couple pilot sites, but we're going to roll out chronic disease management, diabetes, oncology, primary healthcare to all 55 sites in AMPATH's catchment area, and use that as a model for all of East Africa, and hopefully a model for all of Sub-Saharan Africa. And so to me, that's where the future is setting up a model that's replicable. Because I think as long as it's completely dependent on USAID funding, it's going to fail eventually at some point. And I think creating some of these economic models and incorporating that in, and actually charging patients and not viewing them as incapable is part of where I see the future.
So did the government pharmacy have to increase their prices in order to maintain the supply, or?
So the way that I'll give you an example. So let's say this table is a government health center. So this is the government pharmacy, and then we've set up a separate pharmacy that's run in partnership with the government, but separate enough where all the accounts are transparent and we have access.
Physically right next to it?
So it's about a 1-minute walk. It's just in another corridor. And so when patients come here in the government pharmacy and they don't have the drug in stock, then they go back to the cashier and pay for the drugs at our little revolving fund pharmacy. And so that's basically how it works. And the prices that we set were based on what the government had already set. Right. So if the government charges 50 cents for hydrochlorothiazide, we charge 55 cents. And then they get their month's supply of hydrochlorothiazide from us if the government doesn't have it. But if the government has it, then the patients would, of course, prefer to go there first because it's cheaper, which is what we want them to do. We don't want them to come to us.
Right, but I'm just wondering, I don't understand how the government was able to improve their supply. Was it just a matter of...
They weren't. We manage this one. We help them manage this. We ensure that all the stocks are up to par.
No, but for the government one.
They don't. They haven't.
Oh, so...
So if you look at the whole health center as a whole and the access to drugs in the entire health center...
Yeah, that's what was unclear on the slide.
Oh,
okay, let me...
From 30%
when you went
to
back to the
90%.
slides, availability, you were talking about availability for
Right.
the whole.
Oh,
health center, yeah.
okay. I thought that... Okay.
No,
And
no.
your revolving fund
Right,
pharmacy.
because we're part of the government.
Right.
We're just a separate thing. We're a separate entity where we have control over the money. The big problem is even at the ministry side, they have a hard time accessing the money. And so there's a whole, when I walked into this building, I love that there was Department of Procurement and Supplies. It's like, oh, we need that in Kenya. Like, bring the next time you come, I want you to bring somebody from that department, or just bring that whole office there, and we'll figure that out. Like, one of the big challenges is procurement is incredibly difficult. It'll take you 6 months to procure anything. And so we help manage procurement at our pharmacy. And if you look at the whole health center, we now have 94% availability in the health center.
But there's nothing has changed at the government
No,
side?
not really. No. But it will, hopefully. Global Fund has said they're going to give money. I don't think money is the solution. And Global Fund is now worried about the corruption, and they're talking about
Rob Moy's estate is just going to get bigger.
Yeah.
Or
Have you considered any kind of sliding scale of payment for people, and how would you assess that if in fact it were implemented?
So we have a whole waiver system. For patients who can't pay, we have a waiver system that requires the head clinical officer of the SORIAP to sign off, or Lillian, who runs the AMPATH side. And so, our prices are low. Like, we're not operating in a for-profit model. Our prices are low enough that if you can afford anything, you can afford our drugs. But if you can't even afford that, then we have a waiver system. Our goal is to ensure access to patients.
But the social worker is the one that
Right.
says yes.
And they have a form, that does that.
You said you guys have a screening program for diabetes
Yes.
in the community. So, like, what proportion of those screened populations did not know that, or the other way, like, were ever told by their physician or someone that they had diabetes before? I mean, I just wanted to have some kind of sense that what is the missed, like the proportion of population that has missed diabetes, like condition or something like that.
Yeah, and so that's a very interesting question. This is preliminary screening data here from a home-based screening that we did. And so this is just some data. I can answer your question a little bit more detailed in a little bit, but we screened 350, and 47 had a random blood sugar above 7, which is not a diagnostic criteria for diabetes by any means, but we thought that might be the at-risk population. And only 19 came back for confirmation. And so we only confirmed 4 with diabetes. But these are all patients who didn't know beforehand. Now, the other thing that we did was we did a community-based screening where we just set up a tent on World Diabetes Day and screened everybody who came, and found that diabetes was not the big thing, it was hypertension. There's a huge mass of patients walking around with blood pressures in the 200s, and have no idea that, And so that's where, like, when I looked at all the data, I don't even think I looked at the diabetes data once I saw that. I think I even forgotten what the diabetes data was. I think it was maybe it was around 2.5% had diabetes that didn't know it beforehand. But the blood pressure is where the biggest bang for the buck is. And hopefully Jerry will be coming back in January. We'll get back down to work.
That's right.
Yeah. But there's a huge burden of diabetes. Now, we just got the data about a day ago, and I'll send you some of that. It's quite eye-opening. In Webuye, as you go up in age, it's like almost a parallel correlation. Like the higher age, they all have high blood pressure. And so it's very, very enlightening.
And the BMI is still fairly low. It's that same percentage, you think, of...
I haven't done the correlation yet,
Okay.
but we did find a positive correlation with higher BMIs and diabetes. And so, the odd thing with this brand of diabetes is it usually comes on in an instant. Like, it's not like people have, smoldering diabetes for a while like they do here. It just comes on, and all of a sudden they get super hyperglycemic, and then they have to have all the symptoms and have to come in emergently. And there's just one patient I just saw before I left who I've been managing for a while. Came in with an A1C above 14, blood sugars in I'm doing the conversion, what is it? Probably about 500s for about 2 weeks, and was so tempted to put her on insulin. Everything in my body was telling me, put her on insulin. Well, she's going to need insulin. I said, we'll give her 3 days on orals and see how she does. But I'm going to give her a glucometer and see how she does. Gave her orals, and she responded wonderfully. A1C 3 months later came down to, I think, 8. And now it's 6 months later, her A1C is 5.6. And I have her on, I think I basically took her off the metformin she was on. So she's basically on nothing for diabetes anymore. And I don't understand it. But she had full-blown diabetes, was peeing every 5 minutes, everything, all the symptoms. And now it's gone.
And there's no diet change or anything
No.
else that you...
I mean, she did diet changes, but not to a magnitude that I would expect you to go from 500 to not needing anything for diabetes. It doesn't make sense to me.
How frequently do you see that?
I would say in the whole population, there's probably 20% that I can't figure out at all. There's probably another 15% that I'm confused on and think fit this picture. So probably about 1/3.
So 1/3 of diabetes, prolonged diabetes, are those you said type 1, mostly type 1?
Ooh, I don't know what to term these patients. So there's WHO has characterized, there's type 1, type 2, then there's malnutrition modulated diabetes, and then there's atypical African diabetes, which is not a WHO term, but I think if you look at the description of that, that's what we're seeing. And so I don't really know how you describe it. The only thing that matters to me is whether they're insulin dependent or not insulin dependent. So that's how I classify them, because that's what matters clinically. Whether something else matters, I don't know, but that's what matters. And you'll have patients that, you have on orals, and all of a sudden they'll stop responding. You put them on insulin, their sugar will come back. You can take them back off the insulin and try orals again, and they'll respond to the orals again. Doesn't make any sense. So for any undergrads or med students, don't apply what I'm saying now to what you're seeing in America. You'll start killing patients, and I don't want to be responsible for that. Yeah. Yes.
You said you were doing screening for HIV, hypertension, and diabetes with this cell phones.
Right.
What kind of attachments or who's doing it?
So it's we have the simple point of care test, and you use software. It's called ODK Collect. I learned how to program it in about a half an hour. So you could probably even set up something yourself on your own phone if you wanted to. And so you basically just put the questions on a phone and you just thumb through it. It's Johns Hopkins developed ODK. It's Open Data Kit. That's what it stands for. And so they developed that software. It's very user friendly, and you can just basically plug the questions in, and they already have a lot of the questions pre-programmed. So you can just pull them in and put them onto yours. And since the great thing is these all have GPS, and so when you're going to do this, you get GPS coordinates for every person you're going to. So follow-up is better because you're going to GPS coordinates. Nobody has a physical address. It's not like there's any physical address that you can say. It's just, that person's around that cow that usually hangs out over there. It's some of the description you should get. And if the cow moves away, you got to get a new address.
Or die.
Yeah.
Is it physicians who are collecting the data,
No.
or can you send it out with community health
Oh, it's all
workers?
community health workers. So I'd say about 98% of the care at AMPATH is done by clinical officers, community health workers, and 2%, probably less, is functionally done by consultant physicians or physicians.
But you can program the questions.
Yeah. And do concepts and all this great stuff. There's, I've been working in Kenya for 5 years. The things that I've learned are things that I never thought I would have to know. Like I had to learn how to program. I had to learn how to, understand what a concept is when you're doing database stuff. And I'm sure Jerry has some of the same challenges trying to get some of his forms programmed. But you just do what you need to get it done. But it's very simple.
Is there a similar app for hypertension?
You can easily make it. You can make
Can
it.
you program?
So what we're doing with chronic disease is chronic disease has its own thing for the dispensary level. So we're already developing that.
I didn't think Aquanola was going to program it, and I was just wondering if you could modify.
So Aquanola's study is, like we decided some time ago to make Aquanola's study from what CDM was doing.
Right.
And so Aquanola could easily take that if you wanted to. You just need to talk to Kamano. But Martin Wary is programming it. And Martin Wary is one of our programmers, was just listed as getting one of the top mHealth applications. And so this whole thing is one of the top 10, was just awarded